My name is Dr. Kevin Riley from the University of Arizona in Banner Health.
And I'm Sophia Spatafor, an MS2 at the University of Arizona College of Medicine. This is a how-to video on the emergency transvenous pacemaker placement. First, place 4 limb leads from the bedside monitor and 4 limb leads from the EKG machine. No chest leads are needed. Have someone bring the EKG to the room, plug it in, and power it on. Press rhythm, then press leads, and press V1, 2, 3. Press apply to save changes, and press close to clear the menu. EKG screen shows V1, 2, 3. No waveform will be seen on V1 and V3, but V2 will be attached to the pacing wire and will display intracardiac EKG of patient's native beats. There is no pacing at this time. Gather 4 things: the central line tray, the 7 French introducer, 5 French pacing wire, and the pace generator bag. Place the 7 French introducer in the right IJ using standard sterile techniques for central line placement. Sterile gloves are not shown in the presentation to facilitate production, but strict sterile technique should be observed. Maintain sterile garb and full body sheet to place the pacer wire. Open the 5 French non-ballooned pacing wire. Assemble the wire with 4 objects: 2 yellow adapters, alligator clamp on the distal wire. The distal or negative electrode has white writing along the wire. Application of the schwandum. The schwandum allows manipulation of the pacer wire after the sterile setup has been removed. It is often forgotten and it is easy to put on wrong. Note the in-hole and out-hole are different. The out-hole has a soft rubber end with a cutout that will fit on the end of the 7 French introducer. Park the schwandum on the other end of the wire near the electrodes. Keep the entire assembly sterile. Have a non-sterile assistant hold V2 from the EKG machine and attach the alligator clamp to V2. Have your assistant keep the pacing wire sterile. Some physicians prefer to have the non-sterile assistant take control of the yellow adapters at this point. Hold the 7 French introducer firmly and pass the wire through the diaphragm. Maintain the curve of the wire to the left to facilitate the left-hand turn needed for the wire to pass into the RV. Note there are marks every 10 centimeters. Most patients capture between 30 and 35 centimeters. EKG localization uses the patient's intrinsic beats to allow the physician to know where the distal tip of the pacing wire is located. The SA node is at about 16 centimeters and the EKG shows a very large P wave and a small QRS. At the mid-atrium, the P and QRS are of equal size. When the RV is entered, large QRS complexes are encountered. When the wire is seated against the RV wall, a current of injury pattern is encountered. Stop advancing when you encounter the current of injury pattern. V1 shows a roadmap of the EKG changes as a pacing wire passes from the SVC to the RV apex. Occasionally, the tip of the wire will not make the left turn into the RV. Removing the wire and curling it once around the finger enhances the bend in the wire and is very effective at getting the wire into the RV. The alligator clamp is grasped by the non-sterile assistant. The yellow adapter is grasped by the physician, and the pacing wire is disconnected from the alligator clamp. The pacing wire is attached to the extension cord. The thumb screws may need to be opened to seat the male end of the yellow adapter. Make sure the distal or negative lead is placed into the negative hole on the extension. A knowledgeable assistant should handle the pace generator. Plug the opposite end of the extension into the V hole on the top of the pace generator to pace the ventricle. The A hole is used for atrial pacing and is not needed for our procedure. Press the button at the bottom of the generator to open the battery compartment. Place a fresh battery as directed and close the slide. Turn on the generator with the green on button. Default values are present when the generator is powered on. The heart rate default is 80 BPM and V output is 10 milliamps. Verify electrical capture on the bedside monitor and verify mechanical capture by feeling pulse. Determine the pacing threshold by lowering the V output slowly. Loss of capture denotes the threshold value. Set the V output at 3 times the threshold value. Lock the generator with the green key button on the upper left of the device to prevent inadvertent changes. To unlock and make changes to the settings, push the key button again. Hold the wire firmly to prevent movement. Move the schwandum to within 15 centimeters of the 7 French introducer. Extend the plastic sheath and attach the out-hold rubber adapter to the 7 French introducer. Then place a biodisc and tegaderm dressing on the introducer. Verify placement with EKG. A pacer spike followed by a left bundle branch block pattern should be seen. Verify placement with chest x-ray. The end of the pacer wire should be in the RV apex and no pneumothorax should be seen. You can now do the happy dance.